Thanks for the great case, Ryan. Hi there, I'm Meredith Banos, and I'm another member of the Locomotor Training CPG Task Force. I'll be presenting the second of two cases in this series. I also want to acknowledge Kara Gillum, who's one of my current PT Neurologic residents. She completed a case study during her inpatient rehab rotation, and she has supplied many of the videos and patient information in the case to follow. However, I'll be presenting her case from the perspective of how we incorporated the clinical practice guideline from an institutional perspective. Very similar to Ryan's case, we'll be talking about different barriers, including safety, heart rate monitoring, but really the meat of this case will be focusing on the beliefs barriers, and specifically how and when to apply the clinical practice guideline in the context of other locomotor training paradigms that have previously been accepted. The patient we're going to be using in this case is a 42-year-old male who sustained a chronic lumbosacral or cauda equina spinal cord injury in 2007 due to an ATV accident. He is now presenting to the inpatient rehab setting following an acute atraumatic thoracic spinal cord injury following the resection of a T3-4 tumor. Following this person's initial traumatic spinal cord injury, he went from being non-ambulatory and a primary wheelchair user to ambulating with KAFOs and various assistive devices, to becoming independent at the community ambulation level with no bracing or devices. All of this occurred over the course of 10 years following his initial injury. His history of current illness includes a decline in function over the course of the last 2 years, which resulted in him again becoming non-ambulatory 1 year prior to this current hospitalization. At the time of this inpatient rehab initial PT evaluation, this person required moderate assistance for bed mobility. He was contact guard assistance for sitting balance and slide board transfers, and he was unable to perform standing tasks, including ambulation and stairs. He had trace or very weak muscle activation in the majority of his large muscle groups in his lower extremities, per the manual muscle testing scores on the screen. And we saw a floor effect with all the functional performance measures, including the 10-meter walk test, 6-minute walk test, 5-time sit to stand, and Berg. On the ICF model, we see that the findings from his initial PT evaluation contribute to decreased participation in his ability to play sports with his kids and his ability to work. Fortunately, this person had no equipment limitations, as he had many of those needs met during prior stints in therapy. And positive personal factors include a very motivated individual that had previously self-rehabbed, and quite successfully, from a very traumatic injury in the past, and great family support. His stated long-term goal was to return to functional ambulation. Once again, throughout this case, we will discuss three main types of barriers. They include safety, how we would optimally monitor intensity, and most importantly in this case, the beliefs barriers. In addition to some of the safety measures Ryan alluded to in his case, we did use equipment such as harnesses to ensure patient and clinician safety, bracing such as AFOs to protect joint integrity, and vitals carts to routinely monitor the patient's response to activity. In addition, we were extremely fortunate to have institutional support in that we had physician buy-in. On the Locomotor Training CPG resource website, we have physician-specific educational materials. The strategy we used at our institution was to meet with the physicians to educate regarding high-intensity gait training. The resources we used was a recorded presentation discussing the evidence suggesting that high-intensity gait training is safe and has been shown to be no more dangerous than conventional therapy. As a result of our intervention, at our institution, it is now assumed that all patients entering our inpatient rehab facility are okay to participate in high-intensity gait training unless deemed otherwise. Should this be the case, the physician would specify in an order set which vitals parameters need to be maintained with activity. Regarding optimal heart rate monitoring, we were also lucky to have institutional support to obtain chest strap heart rate monitors that were compatible with our patients' bedside tablets. We selected these devices because of the ease of viewing a patient's heart rate being graphed on a chart in real time. Simultaneously, you can see the corresponding percentages of an individual's heart rate max, so you know if they're currently working in the target heart rate zone or not. And this system also tabulates the time spent in each of the percentages of heart rate max, which makes documenting the session much more streamlined. For additional resources on how to interpret the data seen on the screen here, visit the Locomotor CPG resources website. Ryan also discussed some of the resources available on the AMPT's website, including a catalog of different devices available on the market. Additionally, we have video tutorials describing the use of various devices, how to pair different devices, and how to don different devices, just as an example of some of the resources available. Next, we'll be discussing the core of this case example, which is the beliefs barrier. Specific to our case, we had the advantage of being an academic medical center, so we were able to use mentorship through our neuro residency program to guide our resident through her clinical reasoning with this patient. However, we also had what we'll call institutional conflict, in that we've had an inconsistent uptake of the clinical practice guideline at various sites within our healthcare system. Specifically, some of our different settings emphasize different locomotor training paradigms. Regarding intervention selection, our resident knew that she'd be working with this person 5 days a week, and his length of stay was 10 days in our inpatient rehab setting. She knew that she wanted him to work at intensities 70 to 85% of his heart rate max, which was 125 to 151 beats per minute for this individual. And she knew she wanted to target at least 20 to 30 minutes in that target heart rate zone during his 90 minutes of PT daily. If for some reason gait training was not feasible during a PT session, she wanted to emphasize high intensity training regardless of the intervention selection. Our PT neuro resident was deciding between which of two different approaches she would like to take with this patient. The first being the application of the 2020 Locomotor CPG for ambulatory patients with chronic neurologic injuries, which of course includes spinal cord injury. While our patient didn't fit perfectly into the population under study, we still felt the CPG could apply to our patient since he was well into the chronic phase of spinal cord injury, was previously ambulatory, and had a goal of recovering walking function. Within that context, the resident was considering the implementation of the CPG's first action statement, specifically providing high-intensity gait training at cardiovascular intensities greater than 70% of his heart rate max. The second approach she was considering was using an alternative locomotor training paradigm she was exposed to at a different clinical setting in our institution, which involved bodyweight support treadmill training, which is an intervention that is suggested should not be performed to improve locomotor function in the context of improving gait speed and distance, as it is often at the expense of intensity at which a patient is working. This bodyweight support treadmill training approach is defined by the following principles, with a specific emphasis on optimizing kinematics, which is not an emphasis of the clinical practice guideline. Being that we were in a teaching environment, we decided to use the approach of trial and error with mentoring this resident through her clinical reasoning. She first approached this deciding to use some conventional bodyweight support treadmill training. During session 1, she provided 25 to 45% body weight support for this person, attempted to optimize sensory cueing, kinematics, and weight bearing through his lower extremities. On the first trial, the patient is heavily reliant on his upper extremity support, however, based on the variables that were manipulated. In the second video, the resident experimented with decreasing upper extremity reliance. However, this resulted in having to increase the body weight support to 45 to 50%. While it appears that this person is working intensely during these trials, perhaps even more so during the second video, he achieved the target heart rate zone only 29%, or about a third of the total session in video 1, compared to only 16% of the time in video 2. Fast forward to another PT session with this patient, and our resident was still trying to clinically reason and manipulate variables to optimize this person's response to intervention and achieve his fit training principles. She went back to one of her original ideas of decreasing the body weight support, allowing for some upper extremity support, and this time we were only able to achieve about 65% of the person's heart rate max with these specific parameters. We were unable to achieve the targeted heart rate zone on this day. So she decided to switch gears. It was important that she revisited his goals for functional ambulation, which we know factors such as gait speed and distance, not necessarily kinematics, are prognostic indicators for walking function. We switched to overground gait training due to his goals for functional ambulation. We were not consistently getting the cardiovascular response that we wanted when we were emphasizing kinematics, and our overground progressions included decreasing body weight support, increasing gait speed, resisted walking, directional changes with walking, and increasing the distance of gait bouts. The resources that helped guide this approach include the quick reference sheet on the AMPT's Locomotor training website. When we zoom in on this reference sheet, we see that one of the should nots is that clinicians should not perform body weight support treadmill training with an emphasis on kinematics. Additionally, there is another resource summarizing the evidence and comparing various locomotor training paradigms. Here we can see the body weight support treadmill training side by side with the high intensity gait training interventions. And here's an example of what some of our overground gait training trials look like. First, we'd like to point out that in all 3 of these videos, the patient readily achieves the 70 to 85% heart rate max target cardiovascular zone. We'll see that in the next couple slides. But here in this first video, he's in a body weight support harness system. However, we're only using the minimal amount of body weight support allowable by this system, which is just 10 pounds. In this middle video, we've progressed away from a body weight support harness and are using a passive harness system just for safety. There's no body weight support provided. We'd like to point out that this arguably might not be as intense as the treadmill trials. He's ambulating at slower speeds, he's ambulating at shorter distances, but this is certainly a plug for monitoring heart rate in real time. The case made in these videos is while he might not look like he's ambulating as intensely, his heart rate tells a very different story. Finally, this third video is of him just prior to discharge. We've progressed away from the harness system altogether. This is just within his 10-day length of stay. And he's still requiring 2-person assist for overground ambulation. In this person's case, we want to emphasize that it is not the overground environment that is superior to the treadmill. For this patient, it was the combination of allowing the patient to bear more weight through his lower extremities. We were not prioritizing the movement quality, and ultimately that is what resulted in an increased intensity and more variability of practice.
We're going to try to get there, huh?
And then she becomes mute and doesn't speak about why she did it or what was going on.
Everybody has great things to say about his progress, and everybody thinks you're certainly on the right track.
When we revisit the FIT training principles and assess this person's outcomes, there were 6 days for which we were able to monitor his heart rate. On all 6 of those days, we were successfully able to achieve 20 to 30 minutes at least of high-intensity training at 70 to 85% of his heart rate maximum. And that includes whether we were performing high-intensity gait training interventions or just high-intensity interventions in the event that we were not performing gait activities. On this slide here, we see a number of different interventions that were performed with this patient. The orange line represents the maximum heart rate achieved during a single intervention, and the black line corresponds to the percentage of heart rate max during that particular intervention. This slide is significant because it demonstrates that maximum heart rate was achieved during overground training with no body weight support. It's also important to note that there were instances when we were able to achieve the target heart rate zone with other interventions, such as body weight support treadmill training. However, these instances were less consistent, and when we're talking about minimizing unwarranted variability and getting the most bang for our buck, the overground training with no body weight support and no emphasis on kinematics consistently proved to be the most intense intervention in this case. A quick aside, you can see that we achieved greater than 85% of his heart rate max on several occasions, up into the 90s. Again, only with real-time monitoring of that person's heart rate would we be able to see this and adjust for the intensity accordingly. At the time of discharge, this patient had progressed to being independent with bed mobility, transfers, minimal assistance for standing, and he went from being non-ambulatory at the time of admission to ambulating with 2-person assist for 70 feet with a walker within a 10-day period. He was also able to land 3 out of 4 scores on the functional outcome measures during his inpatient rehab stay, again, just in a 10-day period. And importantly, his discharge was to home. Here's a final summary of the resources we discussed in the context of this case, all of which you can find on the Locomotor CPG's website. Thank you for listening. We will now transition to our live synchronous panel discussion. Thanks once again.